Okay, so we are discussing the polytrauma with cervical spine fracture from the critical care. 27-year-old motorcyclist came with the RTA at A&E with suspected spine and chest trauma. He is in hemorrhagic shock secondary to hemothorax. How will you assess and manage this patient? So straight away, this is crisp. I will call for help to trauma team, intensive therapy unit registrar and anesthetist, and will proceed with ATLS protocol in CABCD manner or CRISP protocol. So control of ensanguinating external hemorrhage first, then air management and control of cervical spine as well. You can stabilize the spine by sandbag, tape, or cervical collar, but make sure that cervical collar do not make sores. Assessment: I will first speak to the patient. My assessment will comprise look. My system assessment will comprise of look, feel, and listen. Look for the patient, is he breathing, and then feel it, and then listen to it through and the chest. Look for presence of accessory muscles of respiration, neck, shoulder, chest, and abdomen being used. Presence of obvious foreign bodies in the airway, facial airway injury, and the seesaw pattern of complete airway obstruction. Center cyanosis is a late sign. Then you can listen for the presence of inspiratory stridor, as this indicates upper airway obstruction, laryngeal level and above. Also take note of a grunting, gurgling, liquid or semi-liquid form matter in the upper airways, and snoring sounds indicating the pharynx is partially occluded by the tongue or palate. Expirative V's suggest lower airways obstruction. Croning indicates laryngeal spasm. Feel chest wall movements and airflow at the nose and mouth for 10 seconds. The cervical spine control: semi-rigid neck collar, sandbag and tape, triple immobilization plus spinal board immobilization. Then comes the management of airway. So basic airway maneuvers, these include chin lift and jaw thrust, which open the airway and permit the use of rigid suction devices, young or sucker. You must have seen the young or sucker. We usually use the disposable plastic suction sets, but this is metallic, sterilizable. To clear secretions, and forceps Megel to remove solid debris. So Megel is a forceps through which you can remove from the airway or from the laryngeal or pharynx. Basic airway adjuncts: these include nasopharyngeal and oropharyngeal airways. If a patient tolerates an oropharyngeal then it is prudent to request an anesthetic review, as the airway is at risk of imminent collapse. Complex measures: so endotracheal intubations, or you can divide this into supralaryngeal or supraglottis or infraglottis. So complex measure endotracheal intubation, this requires anesthetic expertise and can be achieved through the mouth, orotracheal, or through the nose, nasotracheal intubation. Surgical airway, this requires a cut down through the tissues, cricothyroidotomy or tracheostomy. B for breathing and ventilation. So look evidence of respiratory distress, tachypnea, use of accessory muscles of respiration, abnormal asymmetrical chest wall movement, cyanosis, lead finding. So listen: signs of partial airway obstruction, compromises, symmetrical absent breath sounds, additional sounds, air or fluid, hyperresonant to percussion, dullness to percussion, and crepitations. Maintains the patient's oxygenation. Oxygenated inspired air is best provided through a tight-fitting oxygen reservoir face mask with a flow rate of greater than 10 liters per minute. Other methods: nasal catheter, nasal cannula, and NRM masks, non-breathable masks, can improve inspired O2 concentration. Tube thoracostomy in pneumothorax, needle or finger decompression followed by tube thoracostomy, intention pneumothorax. Yes. And then three-way occlusive dressing followed by the thoracostomy in open pneumothorax. Four corner acts as a valve where air goes out of the chest but not enters. So this is actually saying that if there is a tension in the thorax, you go for needle decompression or finger decompression even, and then proper chest intubation. And if it is open pneumothorax, you occlude the three sides and the three corners, and leave the one side or one corner open. So the 12 to 15 liter per minute by NRM mask to keep saturation 95%. Nasal catheter, nasal cannula can give 2 to 4 liter per minute O2. Simple face mask 6 to 8 liter. So simple mask is better than cannula, even nasal cannula, and NRM is better than simple face mask. So why patient is having shallow breathing? Maybe due to pharynx nerve and intercostal nerve injury from cervical spine trauma, and maybe due to hemo or pneumothorax from chest trauma. Yes. So what are the complications of shallow breathing? What are the physiological effects of shallow breathing? So hypercapnia will develop because of the shallow breathing, which will further do the cerebral effects like an initial increase in respiratory drive. The medulla and respiratory centers will increase the respiratory drive, followed by depressed level of consciousness, also known as carbon dioxide and narcosis, and reduced respiratory drive, an increase in cerebral blood flow and intracranial pressure. So whenever there is a high level of CO2 in the brain, so or in the body, so there is a vasodilation of the vessels, cerebral vessels, and this can lead to increase intracranial pressure. That's why in brain injury or in head injury, we usually give high concentration of oxygen to vasoconstrict the vessels, so there is a less circulation. Cardiorespiratory effects: initial compensatory increase in the respiratory drive induced by the elevated levels of arterial CO2 and acidemia. Reduce myocardial and diaphragmatic contractility, which can progress to cardiovascular instability, arrhythmia, cardiac or respiratory arrest, and death. Shift of the oxygen hemoglobin distribution curve to the right, yes, leading to increased release of oxygen to the tissues, which is called Bohr effect. Lung effects: impair alveolar fluid reabsorption and inhibits alveolar epithelial repair. So there will be impairment of alveolar fluid reabsorption, and there will be impairment of the alveolar epithelial repair. Metabolic effects: hypercapnia produces respiratory acidosis. After inserting a chest tube, air column is not moving. Why? So improper placement not inside the pleural cavity, blockage, tissue, or blood clots. So if the air column is not moving after insertion, this means that the tube is improperly placed, not inside the pleural cavity, and there is blockage, tissue, or due to blood clots. So in circulation and hemorrhage control, level of consciousness, when circulating blood volume is reduced, cerebral perfusion may be critically impaired, resulting in an altered level of consciousness. Skin perfusion, this sign can be helpful in evaluating injured hypovolemic patients. A patient with pink skin, especially in the face and extremities, rarely has critical hypovolemia after injury. Conversely, a patient with hypovolemia may have Asian gray facial skin and pale extremities. A rapid 3D pulse is typically a sign of a hypovolemia. Uh, Assess a central pulse, femoral or carotid artery bilaterally for quality, rate, and regularity. Absent central pulses that cannot be attributed to local factors signify the need for immediate resuscitative action. And management definitive bleeding control. Any source of external bleeding has to be controlled. So this is the first target. Appropriate replacement of intravascular volume. Vascular access. Vascular access must be established. Typically, two large bore peripheral venous catheters are placed to administer fluid, blood, and plasma. Blood samples for baseline hematological studies are obtained, including blood cases. Blood samples for baseline hematological studies are obtained, including blood cases and or lactate level, are obtained to assess the degree of shock. Initiate IV fluid therapy with crystalloids. A bolus of 1.5 liter of isotonic solution may be required to achieve an appropriate response in an adult patient. If a patient is unresponsive to initial crystalloid therapy, he or she should receive a blood transfusion. Insert urinary catheter to measure urine output and monitor fluid response. Monitor the patient response to fluid therapy by the clinical parameters of dehydration, capillary refill time, skin warmth, blood pressure, pulse rate, urine output, and CEP. Disability. As soon as the patient's cardiopulmonary status is managed, perform a rapid focused neurological examination. This consists primarily of determining the patient GCS score, pupillary light response, focal neurological deficit. Exposure log roll maneuver is performed to evaluate the spine and any posterior chest injuries. How will you monitor circulation, cardiovascular response, fluid response, so skin target, dehydration status, paleness, capillary fill time, pulse, blood pressure, urine output, mental status, CP, lab base deficit, serum lactate, mixed venous oxygen saturation. Define shock. Shock is a systemic state of a low tissue perfusion that is inadequate for normal cellular respiration. Or shock is circulatory failure resulting in inadequate organ perfusion, cannot meet the metabolic demands. What are the types of shocks? So hypovolemic shock, hemorrhagic shock, trauma, surgery, non-hemorrhagic shock, burn, pancreatitis, diarrhea, vomiting, evaporation, or third space, accumulation of fluid. Cardiogenic shock due to MI, cardiac dysrhythmia, heart failure, pump failure, valvular heart disease, blunt myocardial injury, cardiomyopathy. Obstructive shock can be due to cardiotamponade, tension, pneumothorax, and pulmonary embolism. Distributive shock may be due to neurogenic shock, septic shock, anaphylactic shock, and in septic shock there is a vasodilatation. So there is a which is called distributive shock. Endocrine shock, Addisonian crisis, myxedema, coma, thyrotoxic crisis. Yes. So we have enough questions in this session. So okay, so here we have differences between spinal shock and the neurogenic shock. We will do this in the next video.